really important information to share. We're going to get started. And before we start, though, I'd like to open in prayer. If you would all like to pray along with me.
Yes.
Father God, we thank you for this evening. We thank you for this day that you have brought us through. We thank you for the gathering that we have here and the amazing information that Pastor Ruth is going to share with us so that we can, in turn, help others. Lord, we just praise your name and we thank you for your goodness and we are so appreciative of technology, especially this year. So, Lord, we just give you thanks. And I pray for your Holy Spirit to be present and to reveal your truth to us and reveal the truth of the information here tonight. So that there are so many hurting people, Lord, that need to know you. And use us, Lord. Use us as your vessels to show your love. And show your goodness and show and share the information that we are about to learn tonight. And I especially lift up our sister, Pastor Ruth, this evening, and I ask that you guide her in all that she says and all that she does and all that she thinks and all that she shares. We pray all of this in Jesus' name. Amen.
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 So, Pastor Ruth, are you already sharing my screen?
Nope, I'm going to stop sharing mine.
Okay.
I'm going to make you, I'm just going to stop sharing mine and then you can share yours.
Okay. Okay, when I looked up, it looked different, so.
Okay.
Okay.
Well done.
Thanks. So welcome everyone. I really appreciate everyone tuning in tonight for our webinar. And Pastor Ruth is with us. And so people will be joining and that is perfectly fine. But before I introduce Pastor Ruth this evening, I just wanted to share our new page at ABCOPAD.org. And it is still being built. It's a work in progress. And what you're looking at right now is the new page, as you can see. It's under ministry. If you go to abcopad.org, Women in Ministry is 2 years old already. And yeah, it's hard to believe. So I am honored to be a part of this program that is networking and supporting women in ministry, whether that's lead pastors or women discerning a call to ministry, youth pastors, any kind of leadership in the church. So I don't want this to be about me or about what we do, but I do invite you to check us out and see what we're up to. And we are, as Women in Ministry, sponsoring this webinar tonight. And so we're really, really excited to partner with the ACTS classes that you've seen before. And so, but I wanted to share the screen that you might not have seen it yet. It is brand new. And if you scroll to the bottom, I'll show you here in just a second. Maybe, hold on. You will see that Bud has created for us, at the very bottom, you'll see Women in Ministry Photo Gallery. So that's a kind of a fun slideshow that you can go through to see all the things that we've done. We've had retreats. We have a monthly Zoom meeting that women in ministry have joined in. So it's a great, great networking program, and I just try to support as many women in ministry as I can. So, and as a great segue, Pastor Ruth is one of those wonderful women in ministry. And so at this time, I am going to invite her to share her screen.
Okay.
And I have this amazing introduction. So I had this little mini bio and I just knew it wasn't good enough. So if you bear with me, I'm going to read this because I just want to share just how amazing Pastor Ruth is and her amazing past and how she became to be with us tonight. So at this point, just sit back and relax. And let me introduce you to my dear friend, Pastor Ruth. And before I do this, one more thing I'd like to share is there are going to be times for questions and answers. Pastor Ruth, when she takes over, will be muting everyone, and she'll probably be reiterating some of this. And so you're welcome in the chat section to write a question, and I will be monitoring that as Pastor Ruth is presenting tonight, but there will be a Q&A time later on. So Reverend Ruth S., which happens to be Susan Moore biography. She is the Director of Business Development and Admissions at the Pennsylvania Psychiatric Institute, also known as PPI. She is the Community Liaison for PPI and the Head of Diversity and Inclusion. In 1990, Reverend Moore became one of the Duke of Edinburgh's facilitators, whose aim was to create a world where young people could reach their full potential, whatever their social, cultural, ethnic circumstances were, to complete the Duke of Edinburgh's award and succeed regardless of any barriers, including the lack of previous education. In 1998, selected by the Lord Chancellor on behalf of Her Majesty Queen Elizabeth II to become one of the youngest individuals in the country to be accepted and become a Justice of the Peace in the Queen's Courts of London.
Wow.
In 1999, Reverend Moore became a voluntary 24-hour domestic counselor for Women at Refuge, the UK's national home for abused women and children. In addition to this, Reverend Moore volunteered her time at the YWCA in the Violence and Intervention Program for Abused Women between 2011 and 2014.
Awesome.
She is the 2012 recipient of the Pennsylvania Baptist State Convention Women of Distinction Award for her voluntary work both in the UK and in the US, and recipient of the NAACP Blair County, I'm running out of breath. Blair County President's Award for her trainings and presentations to the community of Blair County. She is a 1984 past graduate of Thames Valley University with a BA in Marketing Management. Reverend Moore graduated from the Academy of Christian Training and Service, also known as ACTS, of the American Baptist Churches of Pennsylvania and Delaware, and we all know that is our beloved ABCOPAD, studying Christian education and church leadership in 2014, where she is now the Dean of Student Advancement since 2016. She was licensed to preach in 2014 and ordained as the Reverend Ruth Susan Moore in 2016. I know it. As well as her full-time job at the Pennsylvania Psychiatric Institute and American Baptist Churches of Pennsylvania and Delaware, she volunteers her time because she has so much extra, right? At UPMC Pinnacle Hospitals as a chaplain. Reverend Moore is a nationally certified instructor by Mental Health First Aid USA to teach both the adult and youth mental health first aid 8-hour programs. She is vice president of the board of the Jewish Family Services since 2016 and past member of Paxton Street Ministries 2011 through 2016 in Harrisburg. She is happily married to our friend and her best friend, the Reverend Keith R. Moore, pastor of Mount Zion Missionary Baptist Church, Altoona, Pennsylvania, where she is also happily first lady. Let's give it up to Pastor Ruth. Woo!
Here.
Yay.
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 We're so glad that you're here. And now, my dear, it's all yours.
Thank you very much. I'm going to ask you to
Awesome.
stop sharing your screen, and
Yes,
then I will share mine.
Awesome.
Can you stop sharing your screen for me?
Sure.
Oh, maybe there's a delay. There's probably a delay.
Hang on here.
Up
The
near
bay
the
is
top,
probably
um,
most likely
Pastor
me.
Sue, there's just a button that says stop sharing. It's red.
Yeah,
There
I
you go.
know. I know. I'm trying to, hold on here a second. It's not showing up for me right now. Oh, there it is. There it is. Okay. My Mac man had to help me.
That's okay.
There you
All
go.
right. So thank you very much for having me, Pastor Sue. So this evening, we are going to talk about identifying signs and symptoms of mental illness and supporting God's people experiencing mental illness. Now, this is going to be pretty compact. I've already said with Pastor Sue that I'm going to share this. Afterwards, I will send it so people will have notes. And also the fact that we have a couple of videos, I thought it was really important that you saw some of these videos so you could really understand and empathize what a person may be going through. So what we're going to talk about today, we're going to identify some signs and symptoms, because no matter how good I am, I'll never be able to teach you to diagnose. We're going to talk about some health problems in the United States and look at some data. We're going to talk about an action plan and what you're going to see out in the community, whether in your congregations, or in the workplace, or even, you know, in any community settings. You're going to see people who are changing before your eyes, and mainly those diagnoses will be depression, anxiety, mood disorders, and psychosis. We're going to talk a little bit about medications, because we're not going to go deep into it, but I'm going to give you some sort of questions that you can ask people and just give you an idea of how some medications work. And then we're going to talk about an action plan for individuals and some of the best things that you can say when working with them. And this goes in segments. So as Pastor Sue said, if you've got any questions, please put them in the chat box. And then at some point she will, you know, she'll bring them up and we'll answer them, or I'll answer them. And also you can ask it yourself once we get to those little stopping points. Okay, so I thought it was really important to show you this slide. Normally the numbers change at 12 a.m. At night, but somehow at 12 o'clock this afternoon, these numbers were still here from yesterday. The reason why I share this with you is because when we first went into the stay-at-home order, we expected in our hospital to see people flowing in. Because a lot of people suffer from paranoia, a lot of people have that, you know, there are numbers of people that have psychosis. So we expected to see people just flood the hospitals, and we had to get ourselves prepared. At that point, I was working 7 days a week, making sure that we had people come in, you know, preparing for people, but that didn't happen. Didn't happen. So I'll get to that in a moment. But one of the things that you see each day on the news, they'll say something like, you know, 104, this is from yesterday, 140,000 positives. They don't talk to you too much about probables. They talk to you about the deaths every day. What they don't tell you is that over 1,700,000 people as of yesterday, they were negative. They don't tell you that side of the story so much. And recovery, I couldn't actually find statistics today for recovery, but this is back in May. Over 40,000 people recovered. So I'm not here to tell you that, you know, COVID is, don't worry about COVID, people are getting better. This is not what I'm talking about. What I'm giving you is statistics that you don't see, but we predicted that as the states started to open and we went from red to yellow to green, we would start to see more people coming into the hospitals. They didn't come when we first went red because they thought, oh, I'm going to catch it. I'm not going to the emergency room. I'm going to stay inside. I'm going to stay at home and deal with it myself. So, so that's what they did. But as it started to open up, all that time being at home started to make people get more sick. People who already had a diagnosed illness, they were getting more sick. So now what we're finding is that we're getting more aggressive people in the hospital because they've waited so long before they went to get treatment. So the numbers in our hospital now are increasing. The numbers in the emergency rooms with people needing mental health services for either current or new diagnosis because they're afraid of COVID, because they became depressed over COVID, because they became depressed because they lost their jobs, is increasing. So I wanted to share that because this is the reality in which we're living. So I wanted to share something about COVID in this as well. So this is what we're going to be looking at, you know, by identifying signs of symptoms of someone that we love, a member of our congregation, and even you may have come across a stranger. What I am supporting you in doing is offering support and intervention of the person developing a mental illness or a crisis. And you're going to offer that intervention until the appropriate steps or until appropriate professional treatment and support is received. So there are many reasons why a person, you know, can be in a crisis. Sometimes it's just behavioral. Sometimes they're just belligerent. But sometimes it is because they have a mental illness. And your priority is not to diagnose, and you're not trying to resolve the situation and cure them. Your priority is to diffuse, stabilize, and get help for that individual. Oops. So why do we do this? I spend a lot of time, one of my big jobs now is I managed to win the contract, the first person in Pennsylvania. I didn't put that on my resume. I thought, I'm in my bio, I thought I would be running out of space, is that the Pennsylvania State Police, the cadets, they are engaging me to teach them how to diffuse situations without arresting the person, and for me to be very candid with you, without them having to resort to shooting an individual. So now I have one on the 29th. I train over 100 new cadets before they even touch the street. So the reason why we do this training is we want to build empathy. We want you to walk in that individual's shoes. We want you to understand that sometimes if that person's charging towards you, yes, your safety is first. Your safety is first, but it's not always a situation like that, but sometimes the results are the same, whether it's an aggressive situation or not. Unfortunately, the negative results are the same. So we want to build empathy. We want to have better questions to ask. We want to be able to have a conversation with the individual, because sometimes people feel that a person going into a crisis means that person's going to get violent. It doesn't necessarily mean that. It's also a very small percentage where it would mean that. And if that ever came about, well, then your safety is first. You're not there to try and diffuse a situation. You're there to keep yourself safe if you're in that vicinity. And then we want to provide information that you can share with your family and friends and anyone within your congregation. So why are we doing this first? Why are you first? You know, we know that the problems are common, even though individuals will not speak about it. A lot of individuals will not tell you. You could be working with someone for 10 years, 20 years, and you will never know they have a mental illness, because it's not the same as someone saying, Ruth, you had open heart surgery. Are you sure you should be lifting this, Ruth? Ruth, don't you think you should take it easy? If I had said to someone, you know, I had depression, lost my job, I was off work for 4 months, but I'm okay now, they probably would view me in a very different way. But because I have a cardiac issue, everybody's going to sympathize with me. So it's always been there. It's always been common. But people tend not to want to talk about it. You know, professional help is not always at hand for many reasons. Some people will not go and seek help because they are embarrassed, because of the stigma, because they feel they'll be discriminated against. And some people cannot even get an appointment. Even up to 1 o'clock this afternoon, I got to my desk and there was a message on my phone, and it was from someone I don't know. They must have given them my number, and the person said to me, I am trying to get psychological testing for my child and had no idea it would be this difficult. Can you help me? Can you tell me whether you do it there? Can you tell me where else I can go? What other organizations will do this? And she said some more things. And that is very common. a lot of times it takes a while to see a psychiatrist. Doesn't mean that a person can't have therapy or any other intermediary support, but to see a psychiatrist, they're aging out, and younger people are not going into this profession. So it can sometimes be a long waiting period before you can get to see a psychiatrist. And that's why they don't often go and seek help. They just don't want anyone to know. They're fed up of trying to get a psychiatrist, so they feel that they can deal with this by themselves. And that is not a good thing. So when you think about a mental illness, it is diagnosable. You know, you normally would start going to your physician first. You'll see a video on this. You go to your physician. They will probably do some medical checks on you. And then once they've ruled all of that out, then they'll start asking questions that are more psychological. But when a person is in an emotional state, when they are going into a crisis, it does affect their whole being. I have spoken to people who have lost their jobs because they have done no call, no shows. They couldn't get out of bed, so they ended up losing their job. They just couldn't function when they were at work, so it resonated into something else like anger or just being a low performer and so on. So they can lose their jobs, or it just makes it very difficult for them to carry out daily duties and relationships. We have had many a times where, you know, we're trying to, I'm actually going through one right now where as the patient advocacy comes under my department, I'm trying to encourage a patient to call his mother, but he refuses to do it. And we've had it the other way around when a patient, we want to do group therapy, family therapy is the best thing you can do. And we want the individual to have family therapy, but the families won't come in. They don't want to know. They've gone through, and we don't judge because we don't know what they've gone through. So it can take a real toll on someone's life if they don't get the support that they deserve. So I'd like to show you some data. It's always good to give you an idea of what it looks like. So when we look at the most common of disorders in the United States, 19% out of 46 million people in the country have anxiety disorder, followed by depression, 6.8, and substance use disorder. And then when you think about, I'm going to go all the way down to schizophrenia. When someone has a name that is disparaging against an individual, or they're saying some derogatory names, they always think of words that are similar to what somebody would refer to somebody with schizophrenia. But when you look at the percentages, it is so low. The characteristics of a person who has schizophrenia, where they act out, where they're not sure what they're doing and so on, it is so low. So a person with depression, with anxiety, that is one of many reasons why they don't want to tell people, because they don't want to be labeled and referred to negatively. So before I go on, are there any questions?
No.
Okay. All right, so depression and anxiety. So I've put those two very set together because they're among the most common of mental illnesses, as you saw on the chart, and they have very similar signs and symptoms, and they can come often. They come often in different ways, but they can come often in a person's lifetime. So when you have depression, when you go into what I would call a crisis, it doesn't stay with you constantly, but when it does affect you, it can affect you for about 2 weeks in a constant phase. And again, it changes everything about you. You may cry more. You may be thinking things that are somewhat absurd. Your behavior changes, your physical well-being. And again, it makes it very difficult for you to communicate. So I'd like to show you now the pain of John's story. John is going to explain to us how he feels. And what I'd like you to think about as you're watching this is the psychological behaviors he talks about, the behavioral issues that he talks about. And let's look at them afterwards as to what they are. But just think about some of the things he says happens to him.
I am now the most miserable man living. Whether I shall ever be better, I cannot tell. I awfully forebode I shall not. To remain as I am is impossible. I must die or be better, it appears to me.
In the anguish of these words, one of America's greatest presidents, Abraham Lincoln, describes his lifelong battle with depression. Throughout history, many famous and extraordinary people have felt the pain and suffering of depressive disorders. Some of them have shared their struggles publicly to bring awareness to this issue that millions of ordinary people also experience. In fact, over 30 the economy is billions of dollars. The cost in human suffering is immeasurable.
Going through it was like a roller coaster ride through hell.
I felt that there was no way out. The pain was beyond description.
The doctor said to me, Michelle, I think you need a psychiatrist. This is getting worse. And I remember reacting, I don't need a psychiatrist. I'm not crazy.
Community life, family, friends, and workplaces all feel the impact of this debilitating illness.
I went to work, but when I came home, I got on the couch, rolled up in a fetal position with a blanket, and I slept.
I felt the burden of the responsibility of our children. I was the primary caregiver because John just couldn't function.
I was also confused as to what I should do as a person, as a relative of a depressed person. Like, what was the best thing to do?
And depression doesn't discriminate.
They come from different socioeconomic backgrounds, different religious affiliations, different educational backgrounds. Depression is so ubiquitous that it really can be anyone. It could be myself, it could be you, it could be the neighbor next door.
Depression is often misunderstood and consequently misdiagnosed. Fortunately, in recent years, a clearer picture of the emotional and the physical symptoms of depression has emerged. Depression is a painful illness, and the pain is real. The good news is there is hope for all those who suffer and for the loved ones who accompany them on their journey through the darkness.
Long story.
John and Michelle started dating as teenagers and have been happily married for 14 years. Michelle describes John as a happy-go-lucky guy who doesn't sweat the small stuff. A few years ago, however, John started feeling sick and his personality began to change right before Michelle's eyes.
Physically, I was a wreck. There were days I couldn't get out of bed. I just laid in bed all morning shaking. I wouldn't even call into work. I would get headaches. I felt nauseous. I was just in a total fog.
There was an episode at work where he started complaining that he wasn't feeling well, and they had to take him to the hospital. Didn't know if he was getting chest pains, chest discomfort. He felt weak.
Heart disease runs on my family. So one of my main concerns was there something wrong in my heart? I just thought I was going to have a heart attack.
And don't forget about, we're going out with everybody on Friday.
Yeah.
It was so different from his normal being. When the kids wanted to play with him, he would not be interested. He would tell them, not now, I'm not in the mood.
I lost interest in everything. I mean, I don't want to do the things I love to do. I love to ride my bike by the shore. It just ended. I just wouldn't ride my bike. My fish tanks turned green. I'd go weeks without even touching them. I'd go days without even feeding them. I wouldn't even go near the tanks.
I told him, let's go to the doctor. Let's see what's going on.
I really didn't want to. You know, being headstrong, macho kind of a thing. But I did.
Can you open your mouth for me?
Like many people, John reported only his physical symptoms when he saw his family doctor for a series of appointments. In fact, a World Health Organization study found that 69% of patients with depression reported physical symptoms as the sole reason for their visit to their primary care doctor.
He gave me all the tests that a doctor could give you. Stress test, Holter monitors, all kinds of blood workup. Everything came back normal.
Everything is normal.
Even stress tests?
Stress test is perfectly fine.
Really?
Once we've done the appropriate workup and diagnostic testing to rule out any other illnesses, I usually then ask some other questions which might be helpful.
John's doctor went through a series of questions with him that are known as a depression screener. This tool helps physicians evaluate whether or not a person might be experiencing depression.
Have you noticed that you've been feeling like you are blue enough where you're crying or want to cry for no good reason?
Honestly, yeah.
Okay.
A lot of mental health care is being delivered in the primary care setting. So it's very important for patients when they seek care in primary care, particularly if they're feeling depressed or they think they might be feeling depressed, to bring it up to their primary care doctor. Often the primary care doctor has questions or questionnaires even that they can give to the patient that can help them spell out the symptoms further.
The other thing I'd like to do is to refer you for some counseling, which I think would be beneficial for you.
Okay.
When you're stressed the way you've been with work and other things, sometimes it's a good idea to talk it out. Also, there are therapists that can teach you relaxation techniques and things of that nature that just help you deal with the everyday stresses that you're going to feel at work and at home. It's encouraging that family doctors are becoming more involved in the treatment of depression. At one time, depression was treated essentially by psychiatrists, of which there are far too few. Now, with the new research and with the education that's available both to physicians and patients, I'm very optimistic that this trend is going to go forward and that both family physicians and patients will be much better served in the future when they come in and do suffer from a depressive illness.
When a person is depressed, it's important to be diagnosed and treated as soon as possible.
Good luck.
Okay. I'm going to move on from that one because I wanted to share with you this because there's so much information. But you notice that when you look at the signs and symptoms, they're not always, you don't actually think straight away that it is a mental illness. He had, what did he talk about? He talked about didn't want to, he had headaches. He thought he was having a heart attack because heart attacks run in his family. Can anybody tell me anything else that they heard? He talked about he was sleeping, he's sleeping a lot. He talked about he didn't, in the behavioral, the doctor asked him, do you feel like sometimes you want to cry for no reason? And he said, yes, he did. And he was withdrawing from others. He didn't want to play with his kids. So that is very disappointing and very hurtful because, you know, the kids are looking up to their dad. They want to play with them. He had young kids and he didn't want to play with them. He had no interest. He was just lethargic. And then when we look at the psychological part, he was always feeling sad. He had his mood swings. So all of these things, but he didn't think it was a mental illness. And why would he? Why would he? You know, when he didn't even want to clean out, he didn't want to do one of his favorite hobbies. He had fishes and he wouldn't clean out the fish tank. So, you know, sometimes we see people, that's another sign and symptoms. If you were at work, and it has happened, I've seen it in the past, and people have talked about it themselves, that, you know, you're at work with a coworker, then everything seems fine. And then over the next few weeks, you might see them wear the same clothes for days, or you might see that, that they look disheveled and so on. It's because they're going through something. And what you're seeing is Today, they've changed from one emotion or one state to another. So these are all signs and symptoms. So just for depression, there are a lot of physical, like I showed you here, physical, behavioral, and psychological symptoms that happen. And it doesn't mean that every single one happens, but they go through this cycle. And, you know, the doctor can either, if they're very experienced, they can pretty much tell you straight away what's going on after tests, mind you, or they may end up saying that they want a second opinion. So they may want to get you set up with therapy or a psychiatrist or a psychologist. So that's the path that you would go down. If you were starting to feel, the first thing you would do is to go to your doctor and then take it from there with regards to the physical and the checkup and so on. Any questions on that?
I have a quick one,
Mm-hmm.
and I hope I'll probably have more as we get further into this. But so for depression, does it just last like a short time, or can it go on for years?
Well, that's a really good question.
Okay, so that would be my question, and I'll, as we go further into it, because we have a woman at our church that probably I should sit and just have a long conversation with you personally about, you could help us out with.
Sure. Yeah. So the answer to your question is yes. As in to both the scenarios that you gave me. As I had showed at the beginning, I said that sometimes you can go through a bout of depression for a few weeks and it's intensive. And in that time, you will see that change in the individual. Now, it can be that they're on medication and they come out of it, or they don't take medication and they come out of it. It just depends on the individual. And I'm going to embarrass myself now because I always forget what the name is, but there is a type of depression that stays with some people almost, you know, for the time of their lives. Once it's identified, and it's very sort of below the radar. It's not intense, but it's there. And it's a type of depression that is just with you. It's not major, but at the same time, it's still there, and that could be with you. Now, you could have someone in your congregation who is a senior perhaps, or even maybe younger, who may have lost a spouse, lost a child. That can put you into depression, but for a period of time. It may not be lifelong, because once you've gotten over it, you can be depressed because you have lost your job. So they're all different types of depression. Some are curable, some are not. But some are some people use medication and some people don't, which I will go into a little bit further.
Okay.
Does that help?
Yeah.
Okay. All right. So then we look at anxiety. So that is, you know, everyone suffers anxiety in their lives. You know, if you're going to take a final, if you're going to drive your first car, if you're getting married, you know, something major in your life, starting your new job. But an anxiety disorder differs from normal anxiety and stress. So it's okay to have normal anxiety and stress. You know, be humble before you do something. It's healthy. But when it's a disorder, it lasts longer, it is more severe. And again, same as depression, it can interfere in your daily life. It can prevent you from doing things. It can be very disabling depending on the nature of the anxiety. So let's look at hope and courage now and see how these people, they're going to break it down into different types of anxiety that people can suffer from.
The next thing I know, the lights are glaring down upon me, and I'm having heart palpitations. My legs feel like jelly. My arms and hands are numb. I can't feel my fingertips.
I was constantly worrying. I couldn't stop. It was as if anxiety just simply took over my life.
I had no control over myself. I used to panic. I used to cry, and I used to get mad and yell and scream.
I would have to turn the lock on the door more than once until it felt right that it was actually locked. So I'd have to reopen it and relock it and reopen it and relock it. Sometimes 3 times, sometimes 4, sometimes 5, sometimes more than that, sometimes just 2 times.
My hands would get very sweaty. My hands would shake. And I would worry if people were watching me and watching my hands.
I started having flashbacks about the car accident. I never knew when I was going to have one. They started taking over my life.
These people didn't know it then, but they were each experiencing the symptoms of an anxiety disorder. There are actually 5 different kinds: panic disorder, generalized anxiety disorder, obsessive.
Oh, that's not good.
There are actually 5 different kinds: panic disorder, generalized anxiety disorder, obsessive.
I'm sorry, this has never happened before. There's always one thing. Let me just move it on a little bit. Oh dear. Not giving up yet. All right, well, I'm sorry about this, but basically they're going to talk about many different types of disorders. And these disorders can affect people in different ways. You heard one lady talk about her anxiety disorder, where she would keep on checking things if they were locked or not locked and so on. Going back to the stove, going back to the house. The older gentleman was afraid of getting old, and he was worrying about, you know, I'm going to die. My friends are dying around me. So that gave him anxiety disorder. This lady had a generalized disorder, where a panic disorder, which it can be very dangerous. She is here describing that, you know, one day she got into her car going over a bridge, and when she was as she was going over that bridge, she started to get an anxiety disorder. She started to get a panic attack. So what she did was she just moved right over to the left lane, crossed 2 lanes and drove off, went into a house and didn't go out again. Which can be very dangerous. So having an anxiety disorder, if you do not get it treated or have some form of therapy or have it under control, it can be potentially very dangerous. One of the ladies had general anxiety disorder, where she was just worried about everything. Her husband had a good job. There were no problems with the household, the kids, but she kept on thinking that she couldn't pay the bills. There was something wrong if the children went out of the house. So basically, all these different disorders, you need to go and get help. The young African-American young man, he had a socialized disorder, in the fact that he could not go out. He felt really nervous about going to school. He felt nervous about going out. He kept on feeling as though, like, if he had to go out to a bar or to a party, he would actually have a drink before he got in the car. So how dangerous would that be? So then they go on to be talking about, you know, some people only need talk therapy. They don't all need medications. Some people needed to go onto medications and have certain types of programs that help them, cognitive behavioral therapy, which talks about the here and now. And this is how they managed to get their condition under control. So this is the young man that was experiencing that, you know, he was a loner. He didn't want to go out with friends, didn't like crowds, and so on. So I think I've kind of gone through that video, that I have to check what's going on with this video. So I apologize. So again, the signs and symptoms of the anxiety is the same. I mean, if it's physical, one can actually feel like they're having a heart attack. If you didn't know, if you've never had a panic attack before, and you were feeling as though your body is becoming out of control, these are a lot of the symptoms that you can go through. Cardiovascular, it feels, your heart starts to pound, your chest hurts. You're going to feel as though there's pain everywhere. Breathing will be difficult. So all of this can happen when somebody is having a panic attack. And if you're not sure, if you're with an individual, when I talk to you about how to help someone, if they don't know they're having a panic attack, you will have to call 911 because it feels the same as having a heart attack. You cannot tell the difference if the person doesn't know which one it is. And then in the behavioral, you notice that as I mentioned to you, the young man, he had to have a drink to leave the house. The lady who was obsessed with leaving lights on and leaving doors unlocked, she kept on going back. She made such a change in her behavior because she was always in fear that something had gone wrong in her house. And then you have this excessive worry when it comes to psychological. So all of this is happening when someone is going through an anxiety or a panic attack. So again, if these things are happening to an individual and they don't know, the first thought is not for them to go to a psychologist or a psychiatrist. The first thought is, I'm having a heart attack. I'm going to have a stroke. They'll probably end up in the hospital, or they will end up going to their physician if it's not continuous. And then they may find out afterwards through more services that it is a panic or a panic attack of some sort. So that one was kind of quick, and because you didn't get to see the video, but how do you help that person? So we want to tell the person that we're here to help them. If we see it happening before our eyes, if we're not sure what it is, we're asking them, that we're telling them that we're concerned, and we're asking if we can help them. We want to ask the individual, do they know what's going on? So even if it is a heart attack, you would ask that individual, what's going on? Do you know what's going on? And if they don't know, and they don't have any form of identity on them, like a medical bracelet or something similar to that, then you would immediately call for medical services. It is okay for, a person who is experiencing signs of a heart attack to get to the emergency room and for it to be found that they were having a panic attack, because it could be their first one and they had no idea, because the symptoms are exactly the same. The blood pressure, if we're in a hospital and we have had people go to the hospital, we had a real situation a few years ago with our CFO. The night before a board meeting, he had what we thought was a heart attack, because he was showing all the signs. Our nurses did what they were supposed to do in checking his pulse, in taking his blood pressure, and everything was high. So we sent him off to the emergency room for us to find out the following day it was a panic attack, and he had never had one before. So the safest thing is, because you cannot tell the difference if the person doesn't know what's going on, is to get medical advice. Now, if they do know, then you would ask the person if you can help them. Sometimes they need your help just to sit next to them while they go through it, so you're close. If they know it's one and they tell you that it is one, then you may reassure them as they're going through this attack that, let's remember, it is a panic attack. Let's stop, think about your breathing, take your time. Just words of encouragement like that. So just find out whatever you can do. And if there's nothing, just stay around them if they allow you to, until they calm down, because it does come to an end. It does come to an end if they know it's a panic attack. And then other things, like you can ask them, well, what did you do before to help you get through this situation? So risk factors that could make a person have depression or a heart or anxiety. If someone is going through chronic pain, if someone has like a life-threatening illness, that can bring on depression because of the pain, because of knowing that you could be on medications for the rest of your life, or it can bring on anxiety. Changes in your hormonal system, recent childbirth, premenstrual, changes in your body can bring on depression or anxiety. And even the lack of exposure. There are countries around the world where their suicide rate is very high because of the depression rate, because of the lack of light, Norway being one of them. And I think Finland is another. But there are a few, and their suicide rates are high because of the fact that people are getting depressed, they feel hopeless, and because they don't have as much light as we are just so used to, that we, take for granted. And then sometimes it's chemical. And when we say chemical and neurotransmitter imbalance, it is something that has been with you from birth, but it's not diagnosed until later in your life. So that's a chemical imbalance of the brain. And then sometimes it's been brought on by something that you've done with regards to substances or alcohol. You can, mainly it's substance misuse, and then having a withdrawal from it as well. And other things as well, stressful or traumatic events. One of the ladies, just before it got cut off, she talked about she was in a car accident. She wasn't even hurt in that car accident. She wasn't even the driver. But years later, she started having panic attacks and dreams about it. So a stressful or traumatic event can cause depression, anxiety, previous episodes of depression, ongoing stress, family history. It's not all, I'm not saying that if my mother had it, I'm going to get it too, or if your mother or your father had it, you're going to get it too, but family history does play a part. And also if you have another mental illness, and we'll talk about that as well as we go into the mood disorders and the psychosis. So any questions on this part? Okay. So what is psychosis? So when we think about psychosis, psychosis is a disorder where someone has lost this sort of their emotions and their thought processes are impaired, and they've lost some touch with reality. So the diagnosis that come under the psychosis is schizophrenia, bipolar disorder, psychotic depression, schizoaffective disorder, which is a combination of schizophrenia and bipolar, and a drug-induced psychosis. And then when this is developing, so when the actual psychosis is developing, it changes, like I said, the motivation of the individual. It can be very difficult for them to function. Again, this is not constant. It can happen for a period of a few days, a few weeks, until they're stabilized. And what it does is it can give them depression, it can give them anxiety, it can give them, they will suffer from irritability, they'll be suspicious of you. They will be, sometimes you will see that the person is blunted, and when I talk about blunted, it's like you can be asking them questions and they are looking straight through you as though you're not even there. They may even nod their head, or they may not even respond at all, or they may even have some inappropriate emotion. There will be changes in appetite. Sometimes they will overeat or they will undereat. They may not even eat for days, but still continue to carry on the way they are. When we see some people come into the emergency room and then they get into our hospital, mainly adults, they may not have eaten for days, but it doesn't seem to faze them because they're in this state of psychosis. And then they have reduced energy, and again, the motivation. And they have that because, you're having psychosis, you're going through psychosis, but yet you're having depression, anxiety with it. So that is so draining on your body. That's 3 disorders already in one. One disorder of psychosis can bring on depression and anxiety. So that's 1, and then 2, and then 3. So there's a lot going on there with that individual. So when we talk about a mood disorder, the mood disorder is exactly as what it's described to be. It elevates, it's an elevation and a lowering of your mood. And sometimes people know that mostly by bipolar disorder, where an individual is high and happy and wanting to do some really, grandiose things one minute, and then they're sleeping for days the next minute. So when you think about that, that can make a person very, very tired, very irritable. In some rare occasions can be dangerous because they're not thinking clearly. Postpartum depression and seasonal depression. Seasonal depression can be termed as like the light, like I've explained to you before, or it can be seasonal because they may have lost someone around a holiday. So holidays may mean something very negative to them, so they get seasonal depression. So this is just telling you a bit more about the psychosis. I have just already gone through that, about the emotions, how they look, how they feel, other disorders that come within the psychosis. So I want to introduce you to Belle. Belle is a young lady who she is having auditory hallucinations, and that comes from the psychosis. Psychosis can make you feel as though you can be delusional, as in you think that, you know, we had a time once many years ago when a person in our hospital thought that somebody was trying to kill the president, and this was many, many years ago. And he happened to manage to find the number and call the FBI. And the FBI actually turned up at our hospital. That's delusions. And then there's hallucinations where the individual feels as though somebody's talking to them, giving them command voices, telling them what to do. So let me introduce you to Belle.
You might as well not even be here anymore.
And everything you're hearing is in her head.
I am a widow.
Hey!
Now, get away.
Stop. I can do better than bits of cold toast if you want to come inside.
Don't do it. I don't trust him.
Don't do it. What's your name?
Don't tell him.
Mine's Tony.
Mine's, I said no. Nothing. I'm just nothing.
Come on. Let's get you water.
You can't trust anything.
Don't trust him.
Don't deserve them.
Have you remembered your name, yeah?
Don't stop it. Why not? I'm hungry.
I know you're hungry, love. Come, take your time. Everybody hates you as well. Him dead as well. Dead.
What if it's poison? Just shut up, alright? I need to eat.
Anything but worthless.
They all told you. They're gonna lock you up. Everything. No, I haven't done anything. Don't deserve. Move! Move!
Hey, wait!
You can't stop now. No, I can't do this. I can't do it. It hurts so much. They all know. Move. They'll catch you. I can't do this. I need my mum. Well, she doesn't need you. Not anymore. She probably hates you and wants you dead. 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 Hates you and wants you dead.
So this is a description of what she was going through. Can anybody tell me what was going on there? What did they see?
Hallucinations.
Mm-hmm. Hearing voices, yeah. So a lot of the times when we are talking to a patient, you know, they will tell us that either the voices are command voices telling them to kill someone, or the command voices are telling them that somebody is going to kill them, or somebody hates them, and so on. Those are the times. It's very rare that it's, how can I explain, nice voices. It's very rare that it's nice voices. Some children, schizophrenia is actually, or psychosis is actually diagnosed later on in life, so between like 16 and upwards. The reason why is because we cannot be sure about, you know, the voices that a young person may hear. And some will not tell you about the voices because they like the voices, but that's rare cases. But mostly this is command voices that were telling her. The lady in black was the voice in her head. They tell you things like somebody's trying to poison you, all sorts of things. That, you know, it's very similar from person to person. There's one or two different nuances, absolutely, but a lot of the times we would classify it as, you know, the voices are trying to kill, for them to kill someone, or somebody's trying to kill them or poison them or something along those lines. So thank you for that. Was that you, Paula?
Yep.
Yeah, thank you for that. Yeah, she was hearing voices, and but with medication and so on, it can be stabilized. So if the person doesn't receive help, it takes them longer for them to focus and to concentrate. So that does affect their growth, whether they be a young if the law enforcement can see what's going on, they'll drop them off at an emergency room. So like I said, they have those delusions, hallucinations. They have, if it's bipolar, they'll sometimes need less sleep because they're on that high. And then they'll be irritable because when they get down to that low, they'll realize that they've had lack of sleep. They will also lack inhibitions. People won't make good decisions when they're going through, you know, a period of this crisis. So I'm going to talk to you a little bit about medication. So any questions on mood disorder or the psychosis?
Pastor Ruth, I have a question for you. Because we're all affiliated with church, I guess I'm hoping I'm not the only one that is thinking this, but at any point in a psychiatric examination or in a hospital or anything like that, does a spiritual issue come up? I didn't know if you were going to get to that later or not, but I know I have personally dealt with that in my, you know, in my congregation. And how do you tell the difference between an actual, you know, psychiatric disorder and possibly some kind of demonic presence?
Right, that's a great question. I don't know that we always can tell the difference. You know, well, let's put it this way. If a person was in the hospital or is receiving treatment, through a series of questions and answers, we will say, for example, you have this disorder. Now, there are individuals, and I've heard of many over the years, and I've seen the notes of many over the years, they believe, even up to, I think, a week ago or so, where God is telling them to do this. So they believe that some of the voices they hear in their head is God giving them instruction. Sometimes it's good instruction, sometimes it's bad instruction, but that's what they believe. If it was someone in your congregation, you would have to look at the signs and symptoms, look at how they're acting, think about what were they like before, when did they get to this point? You know, you will be asking them about, you know, they will be telling you, let's put it this way, they will be talking to you. But then you're going to be asking them questions like, where is this coming from? Why do you believe this? Together, is this in the Bible? These are the sort of questions you would be asking them. You would be encouraging them to go and seek help. If it got to the point where the person was uncontrollable in your congregation, you have the right to call crisis, because the person will be a danger to themselves and maybe others. If they felt that what they are experiencing is demonic, but they are uncontrollable, then you know, you would have to call crisis, or you may decide to call 911. Depends on, you know, what your familiarity is with the services in your area.
Sure.
But we do have people who say, you know, in the hospital, they want to see clergy, they want to see a chaplain, and, you know, the chaplain will speak with them. But there are times when they are negative with regards to, you know, their faith. They're saying they're like this because they were forced to do this because of their faith. And so God wants them to kill themselves or to kill somebody else or to do something that is not of God, that we know is not of God. So it's more a case of we stand firm with what we believe. We don't get drawn into it. If we see the person is being unreasonable, you would have to decide what you believe unreasonable is, whether they need to leave your church for a period of time, whether they need help. And you have to make that determination whether to call crisis because they're going into a crisis, or call 911 because you would like the EMTs to come. Or I don't think at any point you're going to believe that it's a demonic action. Do you see what I mean?
Oh, no, I do. And I appreciate that. And we should all know what our resources are in you know, each of our communities. But
yeah.
I just didn't know if that ever came up in a hospital setting. You know,
all the time.
Oh, it does. Okay. I wasn't sure if that was discussed or pondered at all. So thank you.
Oh, you're welcome. Yeah, that comes up quite a lot. If we have to discuss it because the individual is in mental health, the HIPAA laws are, well, there's HIPAA laws for medical, and then there's Pennsylvania mental health laws. So because of my level in the organization, I'm responsible for patient advocacy. I'm responsible for making sure that patients come into the building, and so on and so on. So I have the right to look into people's charts. But if you are not working with that individual, you cannot look into the chart. So I know that there's quite a large, you know, there's quite a number of individuals who use God, Jesus, demonic phrases to explain their illness. But it is their illness. They may choose what it is they want to add into. They may not even have the choice to choose, but the point is that it is there. It is there. And some people, they want to see clergy because they want those voices and so on to go away. So they're actually strong enough to say, I'm hearing these demonic voices. I need clergy because I need it to go away.
Great. Thanks so much.
You're welcome. So let's talk about medication now. There's psychotropic medications and there are mood stabilizers. So psychotropic medication is for people who have some form of psychosis. They act on the brain and the central nervous system. They change the way chemicals in the brain called neurotransmitters send messages between the brain cell and what's called a synapse, or a crossing. So basically it goes across the brain. So what it does is it targets certain parts of the brain. And then we have the mood stabilizers. Mood stabilizers are, you know, to give you an example, people who may have bipolar, for example. So they balance certain brain chemicals and they control emotional states. So they control the level of your behavior. So can anyone tell me who prescribes these medications?
Psychiatrists?
Absolutely. Yep. Psychiatrists do.
Physicians do also.
Yes, physicians do. Sometimes physicians do, depending on the level or the intensity of the drug. Physicians do. Anyone else you can think of? I think the last one is probably a difficult one. So let's bring it up here. So nurse practitioners, they can also. What we're finding is there are some family physicians who have been in practice for a long time and they feel comfortable about prescribing these types of medication. And then there are the younger ones, or even some who are older, who don't feel comfortable because it does take a lot of leveling out. You have to be on a solid medication regime. So some will and some won't. They will either send you to a psychiatrist, and in some areas, because of the fact that I mentioned earlier that getting psychiatrists now is very difficult, we have nurse practitioners. It's not just us. There are mental health nurse practitioners. These nurse practitioners can do pretty much everything a psychiatrist can do, because they can prescribe as well as do psychotherapy and psychoeducation. So there is one population of physicians, or at least providers, who cannot prescribe. Does anybody know who that is? Well, actually, there's two, but I'll take either one. Anybody know who can't prescribe?
Psychologists.
Exactly. And psychologists cannot prescribe.
Physician assistant? I mean, I know that they can under the care of a doctor, but.
Yeah, and that's similar to the nurse practitioner, but they would probably, a physician assistant would probably, like you say, it's under the care of the physician, so they're probably in serious dialogue before they would prescribe, but they would more likely let the provider do it. But therapists cannot prescribe. So these are just the 3 areas that can prescribe. So when a doctor or the provider is looking for the type of medication to give, he or she's going to have to look at these areas here. How well it works with a particular symptom. Sometimes, you know, providers who have been in business for years, they can tell pretty much which one it's going to be, and then they'll have to ensure that the level that they give is okay with maybe other medications that the person is currently on. The cost is really important. When we first opened the hospital nearly 12 years ago now, I remember an occasion where, you know, the psychiatrists, the inpatient, they wanted to do the best they could for the individual. They wanted to get them stabilized and out of the hospital. So they gave them the best drugs, the best medication. It really helped them, stabilize them. But what they found was when the individual left the hospital, they could not afford to pay for the medication. So then that just caused some issues. So you really have to ensure whether that individual can pay for it. Is it covered by their insurance? And if it's not covered by their insurance, can they actually afford the money to pay for it? Otherwise, you know, you're just back to square one. Can they get it? Now, can they get it can mean so many things. It can mean, do they have transportation to get it at a particular location? Does it come into the pharmacy that they're attached to frequently enough? Because it may be a pharmacy that they're close to, that they always go to, and that pharmacy is not running it. How often the individual has to take it, and what's really important is side effects. Because, and I want to preface this by saying that not every single person and not every single medication gives side effects, but there are side effects to some of these medications, and some medications can work for one person and not for the other. So the reason why I say that is because, you know, that is another reason why some people will not take medications. So also, you never know how long it's going to take per individual for this medication to work. Whatever they've decided that they're going to give the individual, it can take anything from a few days, depending on the individual and the medication, or anything from 4 to 6 weeks. So it's not necessarily a fast fix. Sometimes within those few weeks, the physician may have to adjust the medication. So when we look at the side effects, because I want to cover this in a little bit more detail, it can cause side effects, as I mentioned. Some of it can be irreversible. And for some patients, sometimes the medication that they're on, it may work for a time and not work again, or it may not help at all, even though that same medication may have helped another individual with the same disorders. It's a very difficult process here. It takes time, and that's why we always want people to keep their appointments, keep coming in. So why do they stop taking the medications? Well, I've talked about the side effects. There can be a number of side effects. Side effects can consist of there's weight gain. There is a symptom called tardive dyskinesia, which can be caused by side effects. And those side effects can, it's involuntary movement of the face and parts of the body. That's what it can cause. And then that has to be treated as well. Weight gain, diabetes, slow functioning. It can make you feel drowsy all the time. You can be sick on it, extreme fatigue, dry mouth, restlessness and agitation, and unfortunately, even early death. So I don't want to make this sound like, if you know anybody, don't tell them don't take their medication. You must take the medication. These are some side effects that, when you see the ads on the TV, they always talk to you about side effects on any type of medication. But these are some of the side effects that can happen to individuals when they're taking these drugs, because they are quite intense medication. I mentioned the cost, how expensive it can be, and can you get it? The lack of education. People, if you have schizophrenia or bipolar, you probably will be taking medication for the rest of your life, but it can also make you feel as though you're well. So you end up not taking the medication. And then there's paranoia. We have had patients who have said they can't take this because the medication is making them do this or whatever it is. So they won't take it because they're paranoid of the medication. And then I had just mentioned that, even though the right medication has been prescribed, it can actually just stop working. It can be working for a while and then just stop. And then the stigma. There's always the stigma. People are embarrassed. They don't want people to see that they're taking it. They don't want people to know that they have it. They're embarrassed. And then, like I said, sometimes people feel better. And that goes with the poor insight and the lack of education. And the reason why I say that is because sometimes people feel better and they want to, they think, I'm good, I'm cured. But they don't understand it's the medication that's making them better. And if they stop taking the medication, then they will just go right back to square one. They will be sick again. They will be going into crisis. They will not be stabilized again. So it has a way of telling you, I'm okay now. So they stop taking it. And then we have to start the regime again.
Pastor Ruth,
yes, ma'am.
Before you go any further, we do have 2 questions in the chat box.
Yep.
I'm going to read them both to you, and you can answer them in together or separately. Sure. Petrola asks, are there any natural remedies? And Percinda asks, does a person get immune to the medication?
Well, the first one is yes, there are herbal remedies. There's also 2 things. So herbal remedies, yes. I mean, there are a number of vitamins that you can take. I know B12 is one of them. And there is one which I'm so sorry, but I can email you that name. I know that there is one herbal one that you can take. There's a couple that you can take. And then if you go into a herbal store, they'll tell you. What it does is it's relaxing types of herbal medication. So anything that has a relaxing, not necessarily to send you to sleep or anything like that, but just keeping you relaxed, because keeping calm helps with depression, anxiety, because you are tense. So you want herbal remedies that will relax you. So whatever suits you as a relaxation model or herbal medicine is what you can use. Also, going out, as simple as it might sound, and Petrula was doing it when we started, going for walks, getting out in the fresh air and socializing really does help. It takes your mind off of it. It takes you away from that intensity inside you. Now, that is for illnesses like depression, anxiety. It is still good for mood disorders and psychosis, but it's not, you know, you need the types of medication regime that I was talking about for those ones. So does that answer your question, Petrula?
Yes, I was also just wondering, like, in terms of diet, you know, I'll get like these articles from this one thing I'm subscribed to, just different foods that affect your, you know, help with inflammation or things like that. So I wonder, like, say you had a, you know, diet rich in fish, like, will that help with mood? Or, you know, I don't remember what I've read, but I was
Right,
curious
right.
about that aspect as well.
Having a healthy diet always helps. So
Yes.
something like fish is going to have the omega-3 in it. You know, having the olive oil capsules, they're good for you. It's the same as, you know, having like a healthy diet it does contribute to relaxing you. And, you know, like I said, doing exercise, simple things like that. Increasing alcohol, increasing smoking does not help. Even though some people, you know, there are more people with mental illness that smoke than not, because smoking has a way of calming some people. So to Pacinda's question, I'm so sorry, I had it at the top of I've forgotten the question. What was the question that Petrula gave? Can you tell me, Pastor Sue? Not Petrula, I beg your pardon, Pacinda.
Sure. She asked if a person can become immune to medication or a certain medication.
Yep, absolutely, they can. They can. You know, for whatever reason, we don't know what the reason is, the medication can just stop working. And I've not seen any, you know, real facts as to why exactly, because every individual is different. But yeah, I think, yeah, it says well, I won't go too far back, but it can stop working. And if it does, this is when an individual will either go into a crisis and may end up in the emergency room and so on, or they may realize the difference, because sometimes it's not always a crisis. An individual can feel that it's not working and can go back to their, you know, to their provider and discuss it, and then a determination will be had as to what's going to happen. They may increase the level, change the medication, and so on. Okay.
Thank you.
You're welcome. All right.
Pastor Ruth, this is Mark. I find too, and I have a number of family members that do struggle with some mental health issues and are on medication, and having a good support network that encourages them to remain on their meds, that notices when things aren't working and encourages them to go for a med check or to get things. Could you speak to the importance of a support network so a person's not doing this by themselves necessarily?
Absolutely. Absolutely. So I talked about earlier about having, you know, good family support, having people that, you know, maybe if there's someone that has the best relationship with that individual. So the individual who is on the medication has the mental health issues, can feel as though they're not being judged. They're not listening to commands. They're having somebody who's loving and they trust, and they will speak with them about, you know, how are you doing today? How's the medication working? How are you feeling today? Is there anything that you want to talk about? Can I do anything to help you? All of these are good things to say to someone, but you have to get their trust. And what you've done, Pastor Mark, is taken us into how we can help. But always family support, if it is there, it is so vital to this. Family therapy, because it's no good if you've got, I don't know, let's just say, example, a family of 5, and one person's going off to get medications and therapy and coming home, and nobody in the house knows what happened in the therapy, because you can't support. So in many occasions, we have had people who have come from very toxic families, gone inpatient. Family doesn't come for family therapy, doesn't come to support, but yet then the individual goes back into that toxic environment. It is not good. So it's good to have, if you are in a family, to have a family family support, or an individual within that family to give support.
Thanks.
You're welcome. Okay, so we're going to talk about self-injury now. So I've already given you the answer right on here. The self-injury is people that will self-harm. They're not necessarily trying to kill themselves. What they're doing is many different things for many different reasons. Self-injury does not mean suicide unless it's accidental suicide. Sometimes people want to escape something that's happening. They could be mentally, physically, or sexually being abused and nobody knows. And they have to live that every day. So they start doing things that they can control. You know, there are individuals, you know, sometimes young people, if parents are going through problems or they're divorcing, or, you know, some young people will start to cut because they think, right, if I do this, my parents will stay together because now they're going to worry about me. So they'll stay, they won't leave. Or they might think that they are the problem. So they do it to themselves as some form of punishment. Sometimes they want to get back at someone, if it's relationships, if it's any sort of situation like that. Sometimes people actually do it for relief because something else is happening in their life. And this is the only thing that they can control. So it makes them feel better when they've done it because they can control it. And then there are others who they want you to notice. They want you to say, what's going on? What's happening? So that you can tell, so that they can tell that individual. They won't tell you what's going on if you don't ask them. But if you see something that's unusual on their body, then they'll tell you what's actually happening. Because most of the time, you know, they're doing this as a second resort to something that's happening initially. So when you need to help somebody who is self-injuring, you want to understand that the self-injury is a psychological distress. It's something that they're going through. So we want to be able to be careful in our reactions. We don't want to blame and criticize. We don't want to focus on how are we going to stop this cutting. What we want to focus on is, why are you doing it? What's going on? Because I guarantee you there's normally something else going on in the background why they're cutting. And some of the things that are not supportive is that you can't follow that individual around all day. It's the questions that you ask them about what's going on. And when you find out, if you find out, we don't want to trivialize it because that person's experience may not be ours. We may not be able to understand it. We don't want to be patronizing. We don't want to be criticizing them. We don't want to be telling them off for doing this. And what are they doing to themselves? What do they think they're doing? Are they crazy? You don't want to be using expressions like that. And you must ensure that you're not the person that can cure them. They need help. So let me put it this way. Because you self-injure doesn't mean that you have a mental illness, but you may need to go to a physician or even receive some mental services in order to understand what's going on. But self-injurious behavior is not a mental illness. It is something the person has chosen to do because of something that's happening. Okay, and if you don't help them to get services or they don't get services, try not to threaten to withdraw helping them if you can, or at least find out if there's someone else you can tell that can help them better, because they will just continue to do it. One of the things you will do, some people who self-injure, or people who self-injure, like I mentioned, they're not trying to kill themselves. They're trying to get attention for not in any, what's the word? They're not trying to get attention as though this is okay, this is a joke. It's really serious, but they're getting attention in some sort of way. But sometimes they can make mistakes. So we know that if a person has cut an artery, I know this is common sense, but if they are self-injuring and then they're disorientated or they're unconscious, naturally you're going to call medical services for them. that we want to get them help straight away. But once they get to the hospital and it's been understood that they've been self-cutting, they will likely end up in our hospital, so we can understand from them what is going on and give them some services as to try to get to identify and help with what's actually going on, but then also treat them with regards to their self-injurious behavior. So I have a question, and anyone can throw out the answer or their opinion. Do you think it's wise to just stop a person or stop a person from self-injuring themselves? Do you think it's a good idea to stop them?
It wouldn't get to the bottom of the problem. I mean, you could stop them, but that wouldn't answer the reason why they are hurting themselves. It would just stop them at that moment.
Yeah, that's absolutely right. So, you know, if we see an individual and they are in our services, we're not trying to stop the self-injurious behavior. We might give them other tools. And when I say other tools, what I mean by that is maybe an elastic band. Say to them, you know, if you're going through this and you feel that you need to self-injure yourself, start using the elastic band on your wrist. Start doing that. And there's some other ones that it can hurt you, but it won't cut you. It won't threaten your life or anything like that, until we can solidify and help to stabilize what it is they're going through. And then you work on the self-injurious behavior.
Pastor Ruth, we have a question from Pastor Jay, if you have a moment.
Yes.
How much self-injury has and he says, forgive my words, social component, like social media, etc., since we have so much influence from that lovely, from the lovely internet?
Well, I can answer that in a couple of ways. Social media is horrible for young people. It's horrible. Because social media, you can find ways to self-injure yourself. You can do it because your peers are doing it. Those things can happen, but mostly when you do the first cutting, it hurts. So if something isn't really going on in your life, you're going to stop. You're going to stop because it's going to be an ow moment, you know? So, but social media encourages it. Social media, when I do the youth presentations, social media will tell you places to go where you can find all the different ways of killing yourself. And they say, good luck. So social media for young people who are vulnerable is the worst thing ever made. Because young people, the bullying is increasing on social media, and the peer pressure is increasing on social media. And that can be from ways to kill yourself, to cutting yourself, to bullying another person. It's just getting worse and worse. Does that answer the question?
Well, he put that in the chat box, so hopefully we'll hear from him again. And then I have one other question that says, will we, oh, I'm sorry, it's scooted down before I could read it. Hang on here a second. From Paula, that says, are we going to touch on what services we can call when a person will not get help after many other people have tried to help the person?
Well, we will touch on it, but I can tell you now, if a person doesn't, well, there's a slide for that. So I'm going to get to that. I'll get to that. So hold that thought, but it's on a slide. Okay, so we're going to talk about the action plan. I'm keeping an eye on the time. We're talking about the action plan. So this came from the Mental Health First Aid USA. So this is an acronym that they came up with. It's called ALGE. But basically, it doesn't mean it. The acronym itself stands for this, but the ALGE itself, they just managed to put the words in in good order, because this is not linear. That's what I'm trying to say. So in some places, sometimes we have to assess for risk of suicide or harm. So if you're with a person who is self-injuring and has gone a little too far, of course you're assessing for risk of suicide or harm. If a person has bipolar and is having a crisis and has grandiose ideas, you may have to assess for risk of suicide or harm. And I'll tell you what that means. We want to listen. Very difficult for human beings to listen. We're ready with an answer before we've even heard the end of the sentence. So first we need to listen, and secondly, we need to listen non-judgmentally. Because if a person who is going through a mental crisis is going to trust you, they may tell you things you do not want to hear. So we must not judge. We want to be able to give reassurance and information, and that could mean anything. To a young person, it might mean, all young people use an app. It might be going to a site on the bullying, going to a bullying app because something's happening to them and they're going through depression. It could be anything. To an older person, reassurance and information, giving them reassurance that there is hope and information, places to go. So you need to know, again, what's in your area, as Pastor Sue had mentioned. We want to encourage appropriate professional help, and we've talked about some of the professionals, but what's key is that we want to ensure that the person continues to go and get that help. So we want to encourage them that they get that types of help. So when we're looking at risk of suicide or harm, in some cases, you may be talking to an individual and they trust you, and they tell you that, I just don't feel like I can go on anymore. I don't want to do this anymore. They may say words that are, that make you feel, or what you're hearing is that they want to give up. So the person is having suicidal thoughts or behavior, disruptive or aggressive behavior. They can be doing things where they're a risk to themselves. So, so you want to be, when I talk about assessing, you want to be looking, seeing what are they doing? Do I need to call crisis? Because they may be doing something that may cause accidental suicide. They may be, they could be, well, I hope this doesn't happen here at all in your lifetime, but they may be thinking that they can drive fully drunk, and they know because they're going through something, or they're standing on a building, anything like that. That's the disruptive and the aggressive behavior, playing with knives, threatening, that sort of thing. That's the risk for suicidal harm. And then when we think about the suicide risk assessment, chronic physical illness. Sometimes people, it may not be in the way that I've described it in the previous slide. It could be someone who says, I just can't take this anymore because they've had major backache for the last 20 years and the pain and the medication is not working, the pain is increasing and so on. It could be an injury that they've had that is getting so chronic. It could be the fact that they're on dialysis and they don't want to do this anymore. So they've gone into depression. They want to give up. When people start to say those words, we're going to talk about some questions we're going to ask. And then a mental illness, of course. And then you see the others, the alcohol and have they been taking that when you start to speak to them? We talked about, Pastor Mark asked about, family support. So when you have less social support and you're feeling hopeless and helpless, that is part of a risk of, that's some of the questions you would ask. You know that that person has less family support. So they don't feel as though they have anything to lose. Who's going to miss them? And someone who's probably done it before. If you find out, you can ask them, how did you survive and what did you do for us to get to today? What do we need to do again? Do they have a plan? And I can also tell you that even if someone tells you they don't have a plan, that doesn't mean that they're not going to try to kill themselves. I think it is, there's been some suicide attempts by individuals who want to be killed by police, and over 79% of them, when they were confronted with police because they were in a crisis, they made that decision right there and then. They wanted the police to kill them. And the law enforcement officer had no idea. They were just goading them until they went to attack, and then the police had to shoot. So these are things that you don't hear about, but these are things that I have statistics on. So even if a person doesn't have a plan, it doesn't mean that they may not be thinking that way. So every situation is different. So we want to tell them again that, we're concerned, we want to help, we want to tell them and talk to them about what we've seen, what we saw yesterday, if there is a yesterday to this, and what we're seeing today, what we're the changes that we're seeing in the person. We have to be as confident as we can because we're here to support. If we show fear in our face, they're not going to trust you. They're just not going to feel as though, well, how are you going to help me if you're not helping yourself? Because you look as though you're too afraid to speak to me. We don't want to be judgmental. Said that before. We don't want to express negative judgment. We want to be able to just make sure that we understand what's going on in our surroundings with that individual, and ask them. One of the most difficult things to do is to ask someone, has he or she made a suicide attempt in the past? It's not an easy thing to say, because sometimes individuals think that if they ask them, they might say, oh yeah, that's a good idea. I think I'll kill themselves. It doesn't turn out like that. It's really the fact that they will tell you if they have or if they haven't. And it may also be a way for that individual to speak with you. So we're going to ask them, and we have to ask them directly. Are you having thoughts of suicide? Or even, are you thinking about killing yourself? Sometimes people find the word killing yourself hard to say, but it's direct. It gets to the point. You may not have a lot of time, or then again, you want to make sure that you're clear in the things you say. These are not words that you use in your everyday conversations. So if you're faced with someone who's telling you, you could be sitting in the pews in your sanctuary, and the person's telling you, I can't pay my bills, I can't do this, I can't afford this, I've got no family support, I just don't feel like I want to go on. You can ask them, what do you mean by that? What are you saying? And depending on the answer, you might say, are you actually thinking of killing yourself? The person will either be horrified and you'll see it in their face and say, absolutely not. Or they may not answer you or give you a very slow response and say it's crossed their mind. Or they won't say anything and you can see that that's something that has crossed their mind. And then there's going to be, you may have to put yourself in a situation that you may ask some of these questions. Have you decided how you're going to kill yourself? Have you decided when? Have you collected the things you need? And the reason why you do this is because you need as much information as possible that you can give to medical services or to crisis. Because if a person tells you yes to this, you're obligated to call crisis because they're telling you what they're going to do. And some of the things that we would not say, just pray about it. God gave us physicians and crisis, and they all come from God no matter what. I remember doing a training once many years ago, it was over 10 years ago, and it was in a church in Harrisburg, and a lady came up to me in the break and she said to me, I'm so glad you're doing this, because in my previous church I went to the pastor and said that, I'm suffering from depression. I don't know what to do. I'm feeling like I want to end it all. And he actually told her off. He told her that she doesn't believe in God because she is letting herself fall into this depression. He got the church to lay hands on her and pray, and told her that if she went to get medication or see a physician, then she was weak. So you can't just say, just pray about it. You have to, of course, we're going to pray. That is second nature to us Christians, second nature. But she needs some practical help, or he needs some practical help. We don't want to make them feel guilty. It says that, we have been told so many times that suicide is a sin. But we don't really know that. We don't really know that. We know that we should not be committing suicide. We know that our body is our temple, and God wants us just the way he made us, and he wants us to go back to him the way he made us, and he wants us to go back to him when the time is right. But saying things like you'll go to hell, you'll ruin other people's lives, what about your children? All of these, they're already feeling hopeless and helpless. So telling them this makes them feel even worse. They feel like they're even less than before you spoke to them if you say these things. Thinking that tomorrow's going to be okay, they need help. They need to get help. I would rather have someone you know, go and get the help they need than for me to walk away and say, don't worry about it. It'll be all right in the morning. Just get a good night's sleep. We need to be able to do something about it. If you've decided to make the decision to say what's going on, then you have to be able to act on their response. And keeping them safe. I mean, I'm not saying that you should do this with every individual to give them your contact number. You might end up giving them the contact number of crisis. You may end up giving them the contact number of a resource in your area because that's what's right at that time. Sometimes you could be speaking to someone in a community setting. You're not going to give them your personal details. So give them something that they can refer to if need be. And if it is your number, then it's your number. It depends on the situation that you're in. Find out from them, you know, what do they do on good days? How do they keep themselves calm? What do they do? Do they do exercise? Do they take their medications? Do they make an appointment to see their physician? Do they go to a group? Find out what they do. Encouragement to go back into those situations, because at some point there was some stability. Very likely there was some stability. Okay, but it's a whole totally different person. If the person is aggressive, if the person, you know, has a weapon that they want to end their life with, that's different. As I mentioned at the very beginning, your safety is the most important. So if you can call law enforcement, if you feel you have to, that's what you got to do. We always advise that if you're in a room, if it's just you and an individual in the room, make sure that you are closest to the door if the person is aggressive, because you are not supposed to stay there. You're there to help. If you don't feel you can help, you have to leave. And again, we don't want to leave an actively suicidal person alone unless they are aggressive and you are in fear for your life. However, another thing that we don't do is if the person isn't aggressive, if they're talking to you in a confidential way and they say, you know, I want to kill myself, this is how I'm going to do it, and so on and so on and so on, but I just want to go home now, because those situations have happened. You do not agree to keep their plan a secret. You can still call crisis and tell them this is their address. Crisis, and if you have their phone number, this is their phone number. Crisis will make a call, because I would rather lose that person as a friend and they stay alive than I regret for the rest of my life that I kept their secret and they killed themselves. So that's something that we have to think about if the person is actively thinking of killing themselves. Okay, so they listen non-judgmentally. We want to understand what they're saying, understand the symptoms for what they are. Because again, you're not diagnosis, you just want to see what is going on. We don't want to confront the person in any negative way, criticize or blame, as we talked before. In some situations, the person could be delusional. They could be having thoughts and they could be saying things. So when they make comments to you, you can't take them personally if you're trying to help them, because they may not know what they're saying. It's very likely if they're delusional, they don't know what they're saying. Don't agree if the person is delusional and they think they're seeing spiders growing up the wall and you know that then there is no spiders all crawling up the wall. Don't agree with them. You will tell them words like, I know you can see them, but I can't. If they're telling you somebody's trying to attack them, can you not see them in the room? I know you can see them, I can't. So, but you're taking what they're saying seriously because they can see them. So you want to get them to a place of safety if you can. So, you know, and again, we just don't want to we don't want to have that non-judgmental attitude when we're speaking with them. We just want to get them to a place of stability. So then communication, sometimes it's difficult. Sometimes the person is constantly speaking and you have to listen as much as you can, but if you have to ask questions, because you will, you want to keep your questions short. You want to keep them clear. If you feel you need to repeat them, then do. But don't assume that they don't understand you. Sometimes when a person is in a state of crisis, it takes them a while for the information that you're passing from your mouth to their ears, it takes a moment for it to sink in. So you have to pace yourself. Look at the body language. Look at what the individual is doing. You can sometimes see just by looking at their body language that they can hear you, but it's taking them a while to respond to you because, again, they may be having a third conversation. There may be that conversation in their head, just like the girl in black was talking to Belle, and the cafe owner was speaking to her. They're trying to compute. They're trying to get rid of the voice in their head and then respond to you. So the very difficult situation that can be. So you have to take your time when communication is difficult. If you're not in such a crisis situation where you can stop and everybody stops talking for a while, yourself and the individual, not the voice in their head, but you can stop, then do that. Every situation is different. So let me tell you about Peter's story. So Peter is psychotic and he's going into a crisis. Oh, do that again.
No, I'm not gonna, no. No, stop. No, shut it, no! What, no? No, shut up! No, just. No, it's not. What? No, I can't. No! I don't want to. I don't want.
Sarah. Hi, Diana.
You know Peter pretty well, don't you?
Yeah, pretty well. Help him out when I can. Why?
I was walking past his place and I could see him through the window. I thought he was arguing with someone, but I don't think there was anyone there.
Are you sure he wasn't on the phone?
Yeah, I could see him through the window. He was just pacing around. He looked really upset. I don't know what's going on with him. I was going to pop in and make sure everything was okay, but I thought he might get mad with me or something.
So you didn't knock?
No. He looked really pissed off. I thought I'd come tell you. Do you think we should go see what's going on?
Yeah, probably a good idea. Yep. I'll just go and grab my keys. You want to dump your stuff?
Oh, cool, thanks. Hi, Peter. Are you okay?
Hi, Peter. Is everything okay? I haven't seen you for a while. You seem a bit upset.
What are you doing here? What do you want?
Well, you just seem a bit stressed, and we thought we'd come and have a talk.
Yeah, I suppose. What do you want to talk about?
Well, it's a lovely day. Why don't we go and sit out on the veranda and have a cup of tea and have a talk?
No, it's not safe. You come inside.
Peter, we're your friends. We wouldn't bring you outside if it wasn't safe.
No. I'm staying right here. I'm staying here.
We've had some lovely afternoons on your veranda, haven't we? Remember when I first got Jessie when she was a pup? We sat out here and we drank tea and she licked your jeans.
Yeah, but it's different now.
What if you sit in this chair that's closest to the door, and then if you don't feel safe, you can come back inside?
Oh, no, I don't know.
Please, Peter, we care about you. We just want to have a talk. You can come back inside if you want to.
Okay, can we just leave the door open?
Yep.
Just
Okay, yeah. Yes. What are you looking at, Peter?
they're watching me.
Who's watching you?
I think it's cops. Because they're the only ones who've got keys to my house, and they're putting thoughts in my head, and they keep talking to me and talking and talking. I can hear them all the time.
But what, Peter?
It could be them. It could be aliens.
Aliens? I don't think so.
You don't know anything. Are you a cop? If you're a cop, you've got to tell me. You have to tell me.
Yeah, I'm a cop.
Get out now. Would you go? You have a warrant? Who sent you?
Diana's joking.
That's not funny. That's not funny. How did you feel about a cops coming in the house without a warrant?
I'm sorry, Peter. I'm unemployed. I thought you knew.
Diana's sorry, Peter.
So, are you a cop? Are you a cop? Because you have to tell me. You have to tell me if you are. You have to.
Sarah, he's insane. We should go. These people go nuts and kill people, you know.
I don't think that we should be scared of Peter. He's just scared and upset. You wouldn't hurt us, would you, Peter?
No. I won't hurt you. I won't hurt you. I didn't mean to scare you.
Peter's acting really.
Why do you keep saying my name? What are you doing here? Are you working for them? Because you have to tell me. You have to tell me.
We're just trying to understand. Okay, can you tell us what's going on, Peter?
I don't know. I don't know.
Do you think you could come and sit down here next to me?
She's looking at me. She's looking at me with angry eyes.
I'm sorry. I didn't mean to.
Peter, would you like to sit down? And Diana, would you like to sit down too? Remember, you can go back inside at any time. Okay? You seem really scared. Can you tell us what's going on?
It's getting worse. It's getting much worse. I think my doctor's trying to poison me. So the tablets he gives me, they make me easy to control. So I just stopped taking them. Stop.
Okay, so you've stopped taking your medication.
Of course I did. Would you take pills that poison you? Now they just keep talking to me instead. Because they can't get into my mind. They just keep talking and talking. I want you to shut up.
Peter, calm down. Will you listen to yourself? It's rubbish. Think about it. There's no such thing as aliens, and the pills you were taking were making you better. And now you've stopped taking them, you're worse. God, be logical.
Oh, you don't care. You don't care. You don't understand. You don't know. You don't.
I'm sorry, Peter.
Yeah, you will be. You'll be sorry if they get you. And they get me. I'll get you too, because they hear everything.
Do you think you could sit down again?
You're really scared, aren't you?
Of course I am.
Come on, sit down. Okay, so you feel like you're being watched all the time. That must be really scary.
Yes, it is. Yes.
It's no wonder you're so stressed out. Peter, Sarah and I want to help. Is there something we can do to make you feel better?
No. You can't do anything. Nothing.
We're worried about you, Peter. I'd like to call the crisis team. I think they'd be able to help us out here. What do you think?
No crisis team. I don't trust them.
Why don't you trust the crisis team?
They'll force me to take my medication again, and no, not.
Well, that's possible, but they'll want to talk to you about more than just your medication. Like, they'll try and understand what's going on and try and help you.
They'll protect you from the aliens.
I reckon that the crisis team will come and they'll know what to do and how to help us.
I'll sneak back to my place and call them from there.
No, Diana, stay here. Look, Peter, we've got some options. We could get someone to come out here and talk to you, or we could go to the hospital, or we could just call the crisis team and ask for some advice.
No, I don't like any of those options. I don't want to talk to anyone at all. No one.
Look, I understand. It seems pretty scary. What do you think we should do?
Don't do anything. I didn't ask for your help.
Peter, I'm your friend. If I was as scared and stressed out as you are now, wouldn't you want to help me?
Yeah. You've always been nice to me. You've helped me with my groceries and around the house and stuff.
Well, what can we do? We need to get some help.
I don't want any help. Don't.
I understand that you don't want any help, but we're worried about you, and I think that if we don't run with one of the options that we've talked about, then I'll have to call the police.
No cops. Definitely no cops.
Okay. Well,
Definitely no.
Which of the other options do you want to go with?
I don't know. I guess the crisis team.
Okay.
Don't tell anyone.
Would you like me to call them here and then you can listen to what I say?
Yes.
Yeah?
Don't tell them any lies. Don't.
I'll make some tea for us if you like.
Okay, so we just have a couple more slides to go. I won't keep you too long after this, but I just wanted to go through this. So the one thing we don't want to be is we don't want to be a Diana. Diana proceeded to be sarcastic, which aggravated him. She talked about the aliens, which you can't be brought into this. You notice that Sarah didn't, she wanted to talk about what could they do to help him, and that they were friends, and that and that she wanted to bring him into being part of the decision making, which is really important because if we can make them part of the decision making, that makes the situation more successful. You notice that Peter was disheveled, his clothing was a mess, he was suspicious of them, and so on. And as I had mentioned to you before, you may have just seen at the beginning, it was only slight, that Diana was going to go into his house, and it didn't look like a situation where she should have gone in and Sarah pulled her back. You may know the person very well, and it may be okay for you to go in, but if you're not sure about what's going on, it's better that you don't go in. They were successful in getting Peter to come outside, but if you saw what you saw and Peter would not come out and you are not going in, that is a time when you call crisis, especially if you know the person's history. You could see that he was having a breakdown. He mentioned something that I had said earlier on the slides about people have delusions about the medication is actually trying to kill them. So even though when he's stable, he knows the medication is going to help him, somewhere the medication failed. So now it's turned itself around. He believes that he's now having delusions, that the police are after him, the medications are trying to kill him, the doctor is giving him the medication, so the doctor's trying to kill him, all sorts of things that are going on. And what you saw with Belle and what you're seeing with Peter, these are all researched actions. So if you have never seen a person go through this, this is very much what it can look like if a person is delusional or is psychotic. Any questions on that before we move forward?
Pastor Ruth, quickly, Pastor Jay does have a question. He said when this is over, but
Sure.
Petrula says, is there a national crisis number?
Yes.
Okay.
Well, there is a national crisis number which I can give at the end. Well, you can get that from NAMI. There's a national suicide, there's a national crisis, but you don't want a national crisis. You really want your local crisis. And even if you did call a national one, they would put you through to the to a local one. So you normally find that a crisis is attached to. I'm not quite sure. I know you live near Pittsburgh or in Pittsburgh, Petrula, but normally you'll find crisis are coming from the city office.
There's something called Resolve. I believe it's on Penn Avenue and towards Wilkinsburg. And I'm
Right.
pretty sure that's what that is for. Because when I was working in the emotional support classrooms as a paraprofessional, they would call crisis or Resolve often for the kids.
Right.
And even we've had a call for, and I'm pretty sure that's the number.
Right. And then there's NAMI. They're the national people. They are the National Alliance for Mental Illness. And they are national, and they are also state and then county. So you should be able to find a local NAMI in your area. There'll be a state NAMI. Pennsylvania, there is a Pennsylvania NAMI, and then there's also one for the country. And all you have to put in Google is NAMI, and then you'll find what's more specific to your area. Okay. All right, so we want to be able to give them reassurance. You saw Sarah was doing a great job of that. She was trying to offer the emotional support. She was trying to help him get services. She was trying to provide the practical help. She was giving him options. She really wanted him to get crisis or go to the hospital. The last resort, she said, well, we'll call the police. But thankfully, he did want crisis. And then we want to encourage appropriate professional help. So we told, so when we talk, we're moving away a little bit from Peter now. If it's something that requires hospitalization or crisis, we want to tell people the first thing is to go to your physician. You may or may not know whether he has the individual has a psychiatrist. You may not know what his what their level of services are. So these are the professional people. We spoke about those earlier, but I've also added in here, there's social workers, counselors, there's other mental health professionals. Certified peer specialists is a new thing, I would say, in the last maybe 6 or so years. These are individuals who also have a diagnosed mental illness. They have been stabilized. And what they've done is they become peer support after certification from their local county. And we have them at our hospital. And you generally would see them walking the floor with an individual. So it's more a case of, in a nutshell, you don't know what I've been going through. And the peer specialist can say, yes, I do, because I've been there. So these have been found to be very successful. Certified peer specialists. They are professional helpers. They are in some outpatient centers. They are in our hospital. Excuse me. And they're starting to grow because it's proven to be quite successful. And then types of professional help. If a person is an in or an outpatient, there is the talk therapist. So when you see the therapist, they talk about your situation, how you're feeling. They give you programs to follow and so on. We talked about the medication, and then there's the psychoeducation, where the psychiatrist or the NP, the certified nurse practitioner, will be giving information, education on how a person can look after themselves. And then the psychotherapist is combined with medication and therapy. Psychoeducation does not have medication entailed in it, but psychotherapy does. And one of the things we want to do, there are times when an individual, you've done such a great job that they want to go to you all the time. not necessarily for because they're in a crisis every single time, but they want to go to you, they want to lean on you. So we want to always encourage people. That's not something you necessarily will do, but just in general, we want to encourage people to go to peer support groups for mental illness. NAMI, who I've just mentioned, they will tell you of support groups in your area. You want to be able to, we talked about it earlier, Pastor Mark asked a question about family, friends, faith. We're finding that more people who are going through mental illness, if they have not had services yet, they will normally go to their pastor before they will go to a physician, because they look to the church. If they are in a church, they will look to the church before they'll go elsewhere. And so we want to encourage people to, you know, start to look for things for yourself. And family, go to support groups together. The best way for an individual with a mental illness to get support if he's living in a household is if the whole family go. One of the things we have in our organization is the Hispanic Clinic. And someone said to me once they thought we were discriminating, and I couldn't understand that why. But what we found from an inclusion and an ethnic perspective and so on is that when, firstly, because of the language, we have a strong Spanish speaking population. That was one of the reasons for us opening it. But secondly, what we found was that whenever the patient came for services, the entire family came. Sometimes someone was the interpreter, even though we will not use family members as interpreters, but they came together. And that what that did was it helped that individual and everybody else understand that as a family group, if you're all living in the same household, the person will have wellness for much, much longer. And naturally, we want them to reduce any type of non-medication substance use or drugs. So that is the self-support that we want to encourage. So that's the end of the algae. But what's really important is, I think this was where, I think it was Petruda or Paul, I can't remember who's, so I apologize. Someone said, well, you know, the person doesn't want to help, want help. You might not be the right person. So after all of the good things that are in your heart, the way that you want to reach out and help that person, they may not want help. One, they may not want help. And two, they may not want it from you. Just because you identify doesn't mean that you're the right person. So you want to encourage that individual to, if they're not going to talk to you, to talk to someone else that they trust. If you're in a position to do so, never threaten that person with hospitalization. If you don't, it likely could be a family member. You know, if you don't do this, I'm going to get you put into hospital. That will make them more resistant to any type of change. This is an illness, and it's a serious illness, and and it's to do with the brain. The brain is sick, so we have to remain as patient and as open as we can, whether it be a family member, someone in your congregation, somebody that you may work with. We want to be able to be as patient and try to walk with that individual. So I think one of my first slides is that we want to have empathy for that individual, because they're going through a lot, and they're going through things where society, to a great extent, does not have time for this illness. And we have to, hopefully we're willing to stay open. They may want to, even if they don't want to go to somebody else, they may want to come back to you later. Today just was not the right day for them. So be prepared. Don't feel as though they've slighted you because you're trying to help and they're not taking your help. They may not just want it today. Today, they might think that they can deal with it. Today, they're a little suspicious of you. They may want to see how you walk and talk. And then they may come back to you in the future. So, coming to the end, one of the things that's really important is that if you are ever in a situation where you have to, I didn't know music was going to come. If you are ever in a situation where you have to help an individual, or you've made the decision to help an individual, it is very exhausting. I went through a situation 6 or 7 years ago where I went into the hospital and I was doing my chaplain duties, and this person was the first individual on my cards. I go in, I ask them what spiritual services they want, and before they could, the first thing they said to my response was, I just want to kill myself. I want to find which one of these, I can't remember the word he used, but which one of these tubes I can pull out. This man was in a hospital bed. It was the last thing I expected. I didn't go there for this side of my job. I went there as a chaplain, and he was trying to find ways to kill himself. I didn't know where the call button was in this room. I spent what felt like to me about 30 minutes, and I don't think it was more than 5, trying to talk to him about, how he got to this situation, what was going on. He told me. We somewhat resolved it. And I couldn't leave him. I went through that same scenario. I didn't want to leave this person alone because I didn't know what the tubes were and what they were going to do. So it seemed like a nurse would never come into the room. Eventually he said to me, okay, maybe it was the wrong thing to do, and so on. I'm cutting out a lot of the story. But then just as we felt like we had gotten to a certain level of calmness, that's when the nurse walked in, and I thought, where were you through all of this? Like I said, it felt like 30 minutes. It was probably only 5, but I could not go and see the other 4 patients on my list after that because it was the last thing I was expecting. I was exhausted. I had to go home. I remember my husband was in Altoona and he wasn't here for me. He was in Altoona, and I'm thinking, I'm going through all of this. You have got to take time for self-care. You have got to take time to look after yourself, because Andre Lourdes says, I have come to believe that caring for myself is not self-indulgent. Caring for myself is an act of survival. So you cannot help anyone else until you can help yourself, just like the air hostess or host cannot help anyone, or they tell you when you're on a flight, make sure you got your oxygen mask on before you try and help someone else. So this is the same thing. You've got to take time for self-care. If you are ever put in a situation like this, it is exhausting. You will be worried about the individual. You will think, should I have done more? Can I do more? Should I go back to that person? It takes a lot. So please remember, self-care is very important. We try to tell that to our staff where we work because there's a lot of burnout because of the things that happen every day. So remember that by you identifying the signs and symptoms of someone that you love, someone in your congregation, or even a stranger, you're offering support and intervention. You're not trying to diagnose, you're trying to diffuse a situation, you're trying to help with a mental health problem or a crisis that's happening, and you're going to use this intervention offered by following the appropriate steps, or until appropriate professional treatment and support is received. And that could mean anything. That could mean that the ambulance comes, that could mean that crisis is called, that could mean that it hasn't got to this level, but the person has taken your information in the giving reassurance and information. So thank you all very much. I know we went a little over. I took a 4-hour presentation and dropped it to a 2, and I failed because I'm 19 minutes over. So just remember that, you could be in a situation where you will need to help someone. And because of the fact that we are all Christian, I know that's what we were called to do. So any questions at all, please let me know.
Pastor Ruth, we do have a question from Pastor Jay. He says, my question is, I have seen brain scans of not just those with drug and alcohol addiction, but brain disorders like schizophrenia. Beyond counseling and medication, what is being done to restore the actual health of the brain, like repair the very structure of the brain to allow people to think better?
Well, from the career that I'm in, all I can tell you is that it is a mixture of medication, therapy, psychoeducation, psychotherapy. That's what I know. Now, my organization is owned by Penn State Psychiatry, and they are forever looking at this type of research to do things. I don't have answers for you as to what they've uncovered, but I do know there is ongoing research on curing the brain.
Wonderful. Wonderful. Okay, well, it doesn't look like we have any more questions at this time. I will put up your contact information, or at least your email, probably tomorrow, if that's okay. And that way, anyone that was participating tonight, if they have a question, maybe they can contact you. We will also put up as many numbers as we can find. I'll talk to Pastor Ruth, see what we can find for you, and put that on the different pages. Now, I just want to say thank you, Pastor Ruth. This was phenomenal, and you did such a wonderful job, and this is so appreciated. So thank you for taking time out of your busy schedule and sharing this with us, because I think it is just so important and so timely.
Yes, sure. So anytime.
Thank you so much.
And thank you for the questions.
Don't go anywhere, Pastor Ruth. At this time, Pastor Ruth, if you could share, make Dr. Jeff the presenter. Yes. I am really happy to say that Reverend Dr. Jeffrey Johnson is back in the saddle. He's back from sabbatical, and we're so happy about that. And he is offering a little something to give away tonight. He does this every month with the Women in Ministry video calls, and it's just really, it's fun, and it's really great, and it's very generous. So Jeff, it's all yours.
Good evening, everyone. Before I close us out in prayer, I wanted to share with you this book that we'll be sharing with someone, and that is Making Space at the Well, beginning with the biblical motif of going to the village well for water that sustains life and exploring the communal significance of that well. Psychologist and professor Jessica Young Brown calls on the church, especially in particular the Black church, to rally its historic resilience and creativity to acknowledge and engage those in the pews who are struggling with mental health concerns. She uses the acronym SPACE as she discusses silencing the stigma, presence and persistence, application and action, cautions, expression and exhortation. She concludes with a practical exploration of now what, digging the well and drawing from it. The book has an appendix that features a brief primer on common mental disorders that frequently affect members of our family, neighborhood, and congregation. On the Judson Press Facebook page, there are videotaped interviews with the author and more resources as well. So I encourage you, if you don't get the free copy tonight, that you check that out at judsonpress.com or the Judson Press Facebook page. Now, Pastor Ruth, would you please pick a number between 1 and 15?
I am going to go with my favorite number, and that is number 7.
Number 7, and that is Paul Fitzgerald in Lancaster of the First Baptist Church. And I saw that he did put a comment in the chat box appreciating you sharing this information with us tonight. So again, thank you. There we go, Pastor Paul. I'll be sending that out to you tomorrow.
Oh, wonderful.
And so as we close out our time this evening, again, we thank you, Pastor Ruth. Would you all bow with me in a word of prayer? Our God, we thank you so very much for calling us together this evening and making us aware of those who have distinct struggles in this mental health area. And thank you for Pastor Ruth's clear passion for this matter and the people who suffer from such. Thank you for her information that hopefully has made each of us more sensitive to those who are around us that struggle with this each and every day. Lord, inspire us to pray more for those in our families, in our communities, and in our congregations, especially those who suffer in silence, that they may, by the power and presence of the Holy Spirit, find courage to share. And when they do, may we be ready to listen and offer a helping hand and direct them to those in whom you have given the resources, the gifts, the talents, and the abilities to address these matters. Thank you again for being a God that cares about all of us and all of us, in body, in spirit, but also in mind. Lord, as we call this a night from this webinar, and maybe something else we still have left to do, or do call it a night and just head off to bed, thank you for being an ever-abiding presence in our lives. In your name, we give you great thanks. Amen.
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 Amen. And
Amen.
thank you all
Amen.
very, very much for joining us tonight and taking time out of your busy schedules. Keep an eye on our Facebook pages and on abcopad.org for other webinars that will be popping up. So everyone have a very blessed night.
Good night. And
Good night. Good night, sweetheart. Well, it's time to go.
There she is.
Oh, Minister Valerie, what a way to end an evening. God bless.
God bless.
God bless.
Good night all.